So folks are still rolling in, but in the interest of making sure that we have enough time for our presenters and some discussion at the end, we'll get started. Already you can see a really good turnout. Drs. Goldstein and Miklowitz, great to have you. Just a bit of housekeeping. So these rounds are recorded and people get continuing education credits. So reach out to Jessica Barton if you have any questions about those. And then a plug for our next Toronto Bipolar Research Rounds, which will be on Thursday, May 9th, also at noon, when Dr. Sophia Frangu and Dr. Steve Strakowski will present on the evolution of neuroimaging and models of bipolar disorder. So join us again in May. But with that said, our theme for today is psychotherapy, and we have two of the absolute best trialists and visionaries in this area in the field of bipolar disorder. One a youth specialist and one who's evolved into a youth specialist. We'll have Tina Goldstein go first, followed by Dr. Miklowitz. So I'll start with an introduction of Dr. Tina Goldstein, who's been a close collaborator and friend for the past 18 years, and is based at the University of Pittsburgh, where she works with Dr. Boris Burmeyer and colleagues. She holds the Pittsburgh Foundation Endowed Professor in Psychiatry Research and is a professor of psychiatry and psychology at Pitt. She has a number of leadership roles, both in terms of administration and in terms of mentorship and teaching. She directs the psychotherapy training in pediatric mood disorders. She directs an NIMH-funded postdoctoral training program and has leadership roles within the Child Bipolar Clinic. Overall, Dr. Goldstein's work aims to develop improved prevention and intervention strategies for youth with bipolar disorder, informed by enhanced understanding of the relationship between biological and psychosocial determinants of mood disorders and suicide risk. Her work is consistently funded by leading national organizations such as the National Institute of Mental Health and the American Foundation for Suicide Prevention. She has published and disseminated her work broadly, including over 150 peer-reviewed manuscripts, as well as co-authorship of a very pragmatic book on the treatment of depressed and suicidal youth. Based on her innovation and her impact, her research has yielded the Clermont Young Investigator Award from the Depression and Bipolar Support Alliance. So that's a consumer-focused organization and a big accolade there, as well as the Presidential Early Career Award for Scientists and Engineers. With that said, we're really looking forward to hearing from you, Dr. Goldstein, in particular about your cutting-edge work on DBT. Welcome.
Thank you so much. I'm just going to pull my slides up here. If I can get them to show up. There we go. Can everybody see those okay?
Yeah.
All right. Well, thank you all for joining us today. And I am really excited to be here. It feels a little bit like a family reunion, though maybe not in the way one might think. Despite the shared last names in so many different ways, I'm not biologically related to Ben, nor am I biologically related to David Miklowitz's mentor, who was also a Goldstein. But I think we share a pretty strong academic lineage. And so I'm really grateful to be here with one of my foundational mentors, David Miklowitz, and also my longtime colleague and collaborator, Ben Goldstein, and his group. So today I'm going to be talking about dialectical behavior therapy specifically. These are my disclosures, as Ben mentioned, primarily related to research funding. So we all likely know that optimal treatment for early onset bipolar disorder includes a combination of both mood stabilizing medication and psychotherapy. And so much of this is due to David and others' foundational work in establishing psychotherapy as a critical adjunctive component of optimal treatment for bipolar disorder, first in adults, and more recently in young people. And so David and I have talked at length about psychotherapies for youth with bipolar disorder. And I think what's probably most critical for us to take away is that while there are several evidence-based approaches, these approaches really share more in common than they do different. And in fact, recognizing these common elements is really critical. And so just to draw all of our attention to some of the shared components between these evidence-based approaches. They include family psychoeducation, ensuring that the family understands the symptoms, course, treatment of bipolar disorder and co-occurring conditions. a component of mood monitoring to help the entire family understand, recognize symptoms and early warning signs of mood episodes. Also, skill building of a wide variety, including communication, emotion regulation, and then also relapse prevention. And so recognizing these core components, I think you'll notice are similar both across DBT, FFT that David will talk about in a little while, as well as other evidence-based approaches to treating bipolar disorder, including CBT and interpersonal and social rhythm therapy. So I've really been focused on particularly prevention of suicidal behavior among young people with bipolar disorder. And that's what brought me to DBT specifically. And so some of this came from our early work when I first came to the University of Pittsburgh, working with Boris Bermaher and others on the course and outcome of bipolar youth study, in which we really rolled up our sleeves to try and better understand suicide risk in this population. And essentially what we found in this longitudinal naturalistic study was that on average at age 12, among a sample of over 400 youth carefully diagnosed with bipolar disorder using semi-structured interviews, on average at age 12 at intake into the COBE study, about a third had a lifetime history of suicide attempt. So again, a very young age, not even through the highest risk period for suicidal behavior. And then when we followed these youth on average over 5 years, interviewing them on average annually, what we found was that 20% made a suicide attempt over that 5-year period. And of these, 40% attempted more than once over the follow-up period. And so really these data just further reinforced the exorbitantly high risk for suicidal behavior among young people with bipolar disorder. And so what did this mean in terms of intervention and particularly prevention of suicidal behavior? So when I first kind of came to start thinking about treating and preventing suicidal behavior in young people with bipolar disorder, I was drawn to the literature to see what did we know. And unfortunately, what we found was that no treatments, no psychosocial treatments had specifically been found to be efficacious for individuals with bipolar disorder in terms of preventing suicidal behavior. And these studies are summarized here. And some of them were open trials, pre-post trials. Some had shown decrease in suicidal ideation, but none had specifically shown decreases in suicide attempts, which was really the target for much of our work from there. And so all of this led me to this idea that treatment of bipolar disorder may be necessary and certainly necessary, but may not be sufficient to reduce suicide risk in bipolar disorder. Now, why might that be? Well, first of all, we know that suicidal individuals are most often excluded from clinical trials. These include some of the psychotherapy trials for individuals with bipolar disorder, and certainly also includes the literature on suicide prevention interventions more broadly. So other studies like DBT, CBT that have been found to be efficacious for decreasing suicide risk. Generally speaking, individuals with bipolar disorder have not been included in those samples or have been grossly underrepresented in those samples. So it really left us with a lot of questions about what is effective in terms of psychotherapy approaches for targeting suicidal behavior in bipolar disorder. The other thing we know from a long history of naturalistic research on individuals with bipolar disorder is that changes in mood are not necessarily always closely related with changes in suicide risk. And the vast majority of treatments for bipolar disorder, understandably and purposefully, target mood. And so this led me to my interest in developing dialectical behavior therapy, specifically for adolescents with bipolar disorder. So very briefly, DBT is an evidence-based treatment originally developed at the University of Washington, really to target suicide risk. It was originally developed for adult, primarily women, diagnosed with borderline personality disorder, and at present has been applied to just about every clinical population one can imagine. But essentially, over multiple randomized controlled trials with different clinical samples, what we've seen is that DBT has been associated with decreases in suicidal behavior, hospitalizations, and substance use, while also being associated with increases in social adjustment and treatment adherence. And these are many of the same treatment targets that we are specifically focused on in working with individuals with bipolar disorder. I think it's important to also highlight that DBT targets life-threatening behavior very clearly and prioritizes it in our treatment hierarchy, which theoretically is part of the reason that we believe that DBT may be effective for decreasing suicidal behavior, is our square focus in the treatment on prioritizing any suicidal behavior that arises. And so when I first started thinking about how to implement DBT with adolescents with bipolar disorder, I was really fortunate because Alec Miller and Jill Rathis and others had already made developmental adaptations to DBT for adolescents and their families. And so with their permission, we utilized that approach, the DBT for adolescents approach, and made some minor adaptations through a series of open pilot trials for adolescents with bipolar disorder. Some of these adaptations include extending the treatment over a 1-year protocol to really allow for us to target different mood states, conducting the skills training with family units. In standard adolescent DBT, the skills training is conducted with multi-family skills groups. And what we found in some of our pilot work was that it was more appropriate, given kind of the mood cycling that was occurring, the different psychopathologies across the families, scheduling, that it actually lent itself much better to delivering the skills with individual family units. Of course, we added a psychoeducation module, knowing that this is a critical piece of evidence-based treatment for individuals with bipolar disorder. And then we have an alternating schedule of weekly 60-minute sessions. I'm happy to talk more about the intervention itself, or I refer you to some of our prior papers describing the model. We are certainly not the only ones who have thought about applying DBT for individuals with bipolar disorder. In a recent systematic review in 2023, you can see that there were 11 studies. These included a range of DBT-informed treatments. And so it's important to recognize the difference between what we consider adherent DBT that include a multitude of components versus individual components of DBT that is not the standard model. But essentially what we know, there have been 2 trials in youth with bipolar disorder and 9 in adults with bipolar disorder. Generally speaking, with many limitations, I think the literature is still kind of in its infancy, generally speaking, but overall concluding that DBT has been feasible and acceptable. And so today I want to summarize results from our recently completed randomized controlled trial of DBT for adolescents with bipolar disorder. So the sample includes adolescents diagnosed with bipolar 1, bipolar 2, or bipolar otherwise specified using research operationalized criteria. The sample was 100 youth and their families. You can see here that we did a thorough intake assessment. We then randomized individuals to either receive 1 year of DBT plus medication management or 1 year of standard of care psychotherapy plus medication management at our CABS clinic at the University of Pittsburgh. And it's important to note that our standard of care was probably what I would call a very high standard of care, because it was delivered by therapists who had many years of experience working with adolescents with bipolar disorder and their families, and had been trained in other evidence-based approaches for this population. We then had a blind assessor evaluate these youth over 2 years to examine outcomes. Here's a little bit about the sample. On average, they were 16 years of age, generally female sex assigned at birth, which is consistent with folks both who come to the clinic, seek treatment, and particularly enroll in psychotherapy studies, though certainly a limitation of the work. On average, high representation of youth who identified as sexual minorities, a range of race and ethnicity represented in the sample, on average about middle class. You can see that on average, the youth had been ill for multiple years. On average, their bipolar disorder onset about age 13. About half of the overall sample had been hospitalized in the past for their bipolar disorder. And similarly, about 60% had a lifetime history of suicide attempts. So overall, a pretty severe sample. And so cutting to the chase, what did we find? First of all, we'll look at the 1-year outcomes. And so we were really excited to see that when we compared DBT, shown here in blue, with the standard of care psychotherapy group, shown here in red, that over 1 year, the group similarly improved in terms of both depression, weeks spent with threshold depression, as well as weeks spent with threshold hypomania or mania over follow-up. And so what this told us is that DBT is actually similarly effective as other evidence-based treatments for adolescents with bipolar disorder in terms of stabilizing mood, which was really exciting. These are the more recent data that I suggested earlier. So what you can see here is the 2-year outcome data. And so we've now analyzed all of the follow-up data over an entire 2 years. And what you can see here is that the mood improvement similarly persists in both groups, both in depression and mania and hypomania over 2 years of follow-up. We also found that DBT was associated with greater improvement in emotion dysregulation. And this was true both at the group level, but particularly when we separate out those youth who start with very high emotion dysregulation, shown here kind of at the top of the scale in brown and blue, and that DBT is most particularly effective at decreasing emotion dysregulation for those youth who start very high in emotion dysregulation. Whereas compared to standard of care psychotherapy, those youth do not improve nearly as much in emotion dysregulation over 1 year of treatment, potentially indicating that those youth with bipolar disorder who have more emotion dysregulation may stand to benefit more from DBT as opposed to another evidence-based approach. And particularly exciting for us, this was the first time in the literature that we know of that any psychotherapy has been associated with a decrease in risk for suicide attempt and number of suicide attempts over 1 year of follow-up. Again, this was significant both across treatment groups, but even more particularly among those youth who had a history of suicide attempt at study intake. And so again, you can see there was some subpopulation who had no history of suicide attempt, who pretty much continued to stay low in terms of risk over follow-up. Whereas those youth who had a history of suicide attempt at intake were significantly more likely to show improvement in risk for suicidal behavior over 1 year follow-up if they received DBT as compared to the group that received standard of care psychotherapy. And one of the exciting components of this trial was also trying to better understand what are the mechanisms whereby suicide risk may decrease with DBT. And what we were able to show, summarized here, was that the mechanism whereby DBT specifically was associated with decreased risk for suicide, suicidal behavior, was through this improvement in emotion dysregulation. And again, that was particularly most true among the folks who started off very high in emotion dysregulation. Again, some newer data about 2-year risk. What you can see here is really exciting that those protective effects against suicide attempts continue over 2 years in the DBT group shown here in blue as compared to the standard of care group shown here in red, whereby the average number of suicide attempts as well as risk for suicide attempt more generally stayed significantly lower over 2 years in DBT as compared to standard of care. Just a couple of last thoughts before I wrap up in terms of where do we go from here. So one, I think, particularly promising avenue is about really individualizing care, trying to figure out for whom is which psychotherapy approach indicated and when. And so one potential promising tool may be something like a risk calculator. And so we used COBE data to put together some clinical variables readily assessed in standard clinical practice to see how we could put these clinical variables together to predict 1-year risk for suicide attempt. So a patient comes into your office, how do we know who is most likely to engage in suicidal behavior among this really high risk group of youth with bipolar disorder? And so what you can see here is that we were able to put together these 10 variables on the left that really quite strongly predicted 1-year risk for suicide attempt among any individual. And these are very much like other risk calculators used across different fields of medicine. And in fact, this one performs quite similarly to other widely used risk calculators in the field for heart disease, cancer, and other conditions. So I think this may be one promising avenue for us to figure out who needs DBT, for example, and when. You can see here when we apply the risk calculator to the data that we already have, it actually performs quite well in terms of predicting risk over 1 year as well. And the last thought I want to leave you with is some exciting future directions, which include a recently completed dissemination and implementation trial we call our Ditto study with our fantastic colleagues, Ben Goldstein and his group at CAMH, where we've been studying procedures for training and supervising clinicians, ways to sustain implementation, and gathering data on treatment fidelity and patient outcomes, because certainly it's critical that we show that these data can be replicated elsewhere, these findings with other groups, but also that we can find ways to, in an acceptable and implementable way, train others to deliver DBT and any evidence-based psychotherapy on a larger scale. So some promising preliminary findings from the Ditto study with more to come. And so to wrap up, among adolescents with bipolar disorder, these data show that DBT as compared to other evidence-based approaches show lower risk for suicide attempt and number of suicide attempts over 1 and now 2 years of follow-up. These are mediated by improvement in emotion dysregulation, which I think is exciting to better understand mechanisms, and also moderated by history of suicide attempts. So it tells us a little bit about who are we targeting. In terms of next steps, we're working on analyzing data on cost effectiveness. We know DBT is an intensive treatment, and so trying to determine, are we getting our money's worth from such an intensive treatment? We're also looking at brain-based changes with DBT via fMRI data. Of course, these replication and results from our dissemination study to see how DBT performs elsewhere with other clinicians trained in the model, and some future directions in terms of clinical staging. How do we use risk prediction and other individualized medicine tools to predict outcomes and who is most likely to respond to treatment? So with that, I thank our funding agencies and all of our fantastic collaborators and you all for joining today.
Thanks so much, Tina, for that great overview of DBT and these really exciting findings. Nice to see the updated findings of the longer-term follow-up. So just in the service of time, for folks that have joined late, we're going to go back to back, and I'll introduce Dr. Miklowitz and aim to leave a solid 15 minutes for Q&A, hopefully tapping on some distinguishing but also overlapping themes. So it's a pleasure to introduce Dr. Miklowitz, who's a distinguished professor of psychiatry and at UCLA Semel Institute, where he also directs the Child and Adolescent Mood Disorders Program, CHAMP, which I think is pretty catchy. His research focuses on family, environmental factors, and family interventions for children, adolescents, and adults with bipolar disorder, as well as those at high risk for mood disorders and psychosis. He has received Distinguished Scientist Awards from the Brain and Behavior Research Foundation, or NARSAD, the Society for Science of Clinical Psychology, the Depression Bipolar Support Alliance, and the ISBD. He has published over 350 journal articles, and as well, I think many know Dr. Miklowitz from his best-selling book, The Bipolar Disorder Survival Guide, which has remarkable over 350,000 copies in print, so influencing science, clinical, but also the general population. And a small autobiographical note is that when I first started my fellowship in Pittsburgh in 2006, my very first project was a NARSAD grant focused on family-focused therapy, adding addictions focus to the model you're going to hear about shortly. So David, thanks for joining us.
Thank you very much, Ben. Enjoyed that. Thanks for the kind introduction. Let me just get my slides up here. Okay. Can everybody see that when it comes up, that is?
Yes.
Yes. Okay, good. So first, I want to say I'm grateful to Ben for inviting me, and Jessica Barton for taking care of some complicated details. It was also a pleasure to hear Tina Goldstein's talk, given that she and I worked together for many years, and it's amazing to see how far her research has come in such a short time. And I think it says a lot to be adding a new psychotherapy to this field that can be used with a population that's very difficult, like suicidal bipolar adolescents. I want to talk to you about our work on family interventions, but also some work in the field in general on psychotherapy and its effects in bipolar disorder. Here are my disclosures. I think they look a lot like Tina's, actually, which I guess doesn't surprise me too much. NIMH, Bazooki, Max Gray Fund, Guilford Press. And what I'd like to do is start off by talking about our meta-analysis of bipolar psychotherapy trials. I was fortunate to do a sabbatical at Oxford University in 2006, and I was able to connect with Andres Cipriani and John Geddes, who were experts in meta-analysis. And I didn't really know what meta-analysis was going in. I knew that vaguely it was studying trials together, or really studies of trials as subjects to try to draw some grand conclusions about what does and doesn't work in a given population. So we dug into this literature and found 39 trials that had compared different types of psychotherapy with mood stabilizers as either acute or maintenance treatment. By that, I mean either treating an episode or trying to prevent recurrence. But only 20 of those compared did the comparison we were interested in, which was pharmacotherapy or medication management with a manualized psychotherapy to treatment as usual with medications. So both groups got medications, half got some form of manualized psychotherapy, which I'll define in a moment, and the others got usually some sort of supportive therapy, case management, symptom check-ins, something other than a clear manualized therapy. The manualized treatments we were interested in were CBT, interpersonal and social rhythm therapy, family and conjoint therapies, and this sort of large category called psychoeducational treatments, which in this case comprise both group treatments, group psychoeducation, and individual psychoeducation. So we're really interested in, first, does a manualized psychotherapy work better than usual care when added to medications, but also is there any evidence for one over the other? Now, this is a kind of chart you see in a meta-analytic study where you can compare different treatments even though they might have come from different studies. So not only can you compare CBT to whatever treatments it's been compared to in individual studies, but you can also compare it to how treatment as usual, for example, did in a different study, or brief psychoeducation, or IPSRT. And the darker the line, the more studies there are that had that pairwise comparison. We're mainly interested in one-year recurrence rates. And clearly the more studies were done on CBT, but we also looked at recovery from depression, recovery from mania, which I wasn't entirely thrilled with because a lot of the patients in these studies don't start off in mania, and a broad category called treatment acceptability, which is, do patients stay in studies or not? Here's there's a lot of details in this I don't want to go into, but here is the overall finding, which is that manualized treatments cut recurrence rates by almost 50%. The odds ratio here was 0.56, meaning there's basically a 44% reduction in recurrences if you're in one of these CBT, interpersonal, or psychoeducational, or family treatments. But the interesting thing about network meta-analysis is it allows you to look at things like what intervention strategies are most effective, or what formats for delivering treatment work the best or show the most effect on recurrence. And it turned out that, well, first, psychoeducation and skill building, which is really a theme in this literature, was the most effective compared to such things as supportive counseling, or checking up on symptoms, or other things that people do in therapy. So psychoeducation and skill building in a family or group format was more effective than the same psychoeducation in an individual format. And that was one of our strongest findings, that if you bring in essentially advocates for the patient, relatives, or you work with in a group where you have sponsors or other colleagues who have the disorder who can help you out in crises, that then you have an easier time implementing these skills, is what we think. We don't have the mediational analysis to prove that, but we do think it's a statement for community care that at some level, both the family or a group format can be an important adjunct to medication. We also looked at individual methods of doing therapy, and self-monitoring emerged as a strong predictor of lower recurrence rates. So just simply asking patients to keep track of their mood and sleep was in itself a predictor of lower recurrence rates. And although that's usually associated with interpersonal therapy, a lot of these treatments did some version of that task. Maintaining regular daily routines was associated with a lower depression rate. And of course, the components like having a family format. Cognitive restructuring turned out to be a good predictor of reduction in depression. And communication skills training, which primarily occurred in family therapy, but we also saw it show up in group psychoeducation. Some of the CBT treatments did that, trying to teach patients how to effectively communicate to reduce stress in their family milieu or in a personal milieu. Now, one of the things we're trying to do with this is put together treatments that essentially have these elements in them in a rotating fashion. It may be that with some patients you can do daily routine monitoring and self-monitoring, and you don't need to get into cognitive restructuring, whereas with other patients that might be the primary focus, or in some patients, family conflict is at the fore, and you may want to emphasize communication training. So this, I think, allows you a little bit of flexibility in working with patients on an outpatient basis. Many of you know we've done work primarily on a treatment called family-focused therapy, which is this model of psychoeducation and skill building applied to families. So usually the patient has just had an episode, and after an episode, it becomes engaged in this treatment. And there are three components to this treatment: psychoeducation, communication training, and problem solving. Psychoeducation really means not so much just giving information about the disorder, but also talking about early signs of recurrence, how to prevent those recurrences from getting out of hand, self-management techniques like sleep-wake cycle management, along with communication and problem solving as a way of reducing the level of tension or expressed emotion, as we call it, within the family environment. We've now done 11 studies on this treatment. Here are basically a summary of the results. Some of this went into the meta-analysis. In fact, we've had 5 trials with adults, 2 with adolescents, 2 with kids at high risk, 1 with adolescents at risk for psychosis. And generally what we're finding is that over these studies, first, depression stabilization is one of the most consistent findings. We're able to reduce levels of depression, reduce recurrence risk, so the likelihood of either rehospitalization or recurrence, symptomatic recurrence, and improvement in functioning and quality of life. That doesn't mean every study found the same thing. These are trends across different studies that we think can be, we think we can make a claim that this is an empirically based treatment. We recently did a study on kids at risk for bipolar disorder. So these were 127 kids who had parents who had bipolar disorder, or at least a second-degree relative with bipolar disorder. And we used the Pittsburgh definition of high risk, meaning that the kid had depression or bipolar not otherwise specified, or unspecified as we're now calling it, meaning they had short manic episodes, more lengthy depressive episodes, but usually the manic or hypomanic episodes only last a few days, but they're recurrent. So the question in this study is, could we reduce the likelihood of a next episode? And this is a curve showing when did the next mood episodes occur when they got either family-focused therapy or a comparison that was also 4 months long, although not as many sessions, called enhanced care, which was also a psychoeducational treatment, but without the intensive family component. And the main finding here was that we were able to delay mood episodes, primarily depressive episodes, over a 3-year follow-up period. Another finding was we saw an effect on suicidal ideation, particularly in kids who had high suicidal ideation to begin with. So when we bifurcated the sample into those who had high and low levels of suicidal ideation, we saw that those who got family therapy showed reductions in suicidal ideation over the 3-year follow-up. And in terms of attempts, we saw an effect there as well, although the number of attempts was fairly low. Only about 10% had a clear attempt, but those were less common in the family therapy than in the enhanced care. I wanted to just say a few words about some of our assumptions in family therapy. One is that when you do psychoeducation, and this is sort of the more clinical part of the talk, when you do psychoeducation, it's not enough to just expose people to illness information. Like people have asked me, for example, why can't you do a treatment like this online? Why can't you just direct people to a website and teach them how to recognize changes to their symptoms and develop relapse prevention plans? Well, maybe you can, but we don't think that's enough. That's just a passive learning. And what we're seeing in the meta-analysis is it's very important for the patient to be actively involved in psychoeducation. An example of just education might be bipolar people are exquisitely sensitive to changes in sleep-wake cycles. You could take it a step further, which is what we try to do in FFT, to personalize it. personalizing that same information might take the form. The last 2 manic episodes I had came after periods when my sleep schedule got way off because of traveling. So the person is now seeing the relevance of that piece of information for themselves. Then you can take it a third step, which is to help them set up a sleep-wake cycle plan or rate their daily adherence to a sleep-wake plan, kind of like what you would do in IPSRT. That's where we try to get to, is not only learning the information, but applying it in your day-to-day life so that it works for you. I think I'll skip over this and talk a little bit more about communication training, because this is a real core part of this treatment, is teaching families not to do less criticism, more problem solving, more requests for changes in other people's behaviors, active listening. This involves role playing, in which we sit people down, say a parent and a teenage kid or a young adult, and have them talk to each other while one listens in this sort of very practical way, nodding your head, paraphrasing, as we would teach someone to do in, say, when they're learning to become a therapist, or expressing positive as well as negative feedback, or putting negative statements that would be considered a criticism into a positive form. I want to give you an example, just a quick clinical example of that, and then I'll wrap up. Here's a communication training example that attempts to address criticisms in a family which has a father, a mother, and a 16-year-old boy with bipolar 1 disorder, who also in this case had suicidal ideation. In this segment of the treatment, the father said to the son, "I really resent the hours you keep. You always come in later than we've agreed on. You're loud and you wake us all up. It makes me think you don't take your illness seriously." Now, this is the kind of statement that we would consider high in expressed emotion. It's critical. It involves the negative attribution. You're doing this on purpose. You could be much better if you would try harder. The son gives the one-size-fits-all response of an adolescent, rolls his eyes. Whatever. Father says, "You have to choose to get to sleep on time so you don't go wacko again." So again, there's this element. You have a choice as to whether or not to be functional. What does the therapist do? So the first thing the therapist would do is validate the dad's concerns. You can say, "I can see it upsets you when Evan comes in late and wakes everyone up. You're angry, but you're also concerned about his health and well-being." So there's a bit of reframing here. It's not that you're just resentful of his behavior. You're also worried about his health, as a good father should be. Dad latches onto that and says, "Of course." But consider how you're delivering that message. You care and you don't want him to get hurt, but I'm guessing he only hears the anger part. And then you bring in Evan. Evan says, "That's all I ever hear from him, one criticism after another. No matter what I do, he's always pissed off." Therapist: "Dad, I wonder if you'd be more effective in getting your point across if you said it in a more positive way." Now, at this point, we whip out what many people who are familiar with FFT know is our famous handouts. We'll hand out something like this. Here's how to make a positive request. Can you say what you'd like him to do differently, how it would make you feel? And use stems like, "I'd appreciate it if you would," or "It's important to me that," but make your request positive. Don't hide a negative statement or a criticism within it. So Dad takes his hand out and says, "Okay, Evan, I'd appreciate it if you would come home earlier, or at least let us know if you're held up somehow." He looks at the handout. "That would make me feel like you weren't just blowing me off." All right, so we got there part way. Therapist says, "Good start. Evan, what did you think of what Dad just said?" Always important to get the recipient's feedback. Evan says, "The first part was okay. Was that what he was supposed to do at the end?" The therapist says, "Dad, can you try again? Only this time add something at the end about how that would make you feel." Dad says, and here we're into the rehearsal personalizing phase. "Okay, Evan, I'd appreciate it if you would come home earlier or let us know you're being held up. Text me or something that would make me feel like I'm being respected." Therapist says, "Better. Evan, what did you think of how your dad said that?" Evan said, well, he said it better, but I don't know if I'll be able to do it. Dad says, you'll do it if you want to keep using the car. At this point, the therapist has a choice. He can get into, or she can get into using the car or problem solving. Instead, the therapist goes back to skill training. Says, Dad, nice job with that request. Now let's talk about how you might practice this at home. Now, this is a critical element, I think, of FFT, is not just sort of following the family wherever they go, but sticking with skill training, even when it seems like they're wanting to go elsewhere. They sometimes want to come in with the latest argument or the latest conflict, and they present it to you, but we haven't found that works very well to just approach families like that. So you're better off with the skill training, where you get people to practice it over time. We've tried using an app to improve that situation. It helps somewhat, but you have to really convince the family that this is going to be useful. The last thing I wanted to mention was a collaborative network that Ben Goldstein is involved in, as well as some other colleagues from Pittsburgh and Virginia Commonwealth, Colorado, and Cincinnati. This is the Bipolar Child Network. It's being funded by the Mizuki Research Fund and earlier by the Milken Institute. This was our attempt to kind of get together different experts in childhood bipolar disorder and come up with common themes, common diagnostic methods, assessment methods, follow a sample over time using the same instrumentation, look at whether or not the docs could follow the same medication regimens and psychotherapy regimens. And the group was interested in metabolic indicators also. So we put in some measures of metabolism and inflammatory markers along the way. I won't go into this in detail, but each site is recruiting kids who are between 13 and 19 years old. We do a full diagnostic interview, and what's different here is the network meets together to evaluate the appropriateness of including a particular patient and also talk about the treatment regimen. So you have the benefit of extra input from experts. We measure a number of different variables, including inflammation, a C-reactive protein. We do an online reporting of moods. The kid does an ecological mood ratings, and they're followed for a year with one of the key questions being medications. Do the docs use the same principles in changing medication? How do they deal with non-adherence? Can we have a common set of guidelines, which is really the goal of this, a set of treatment guidelines for kids and adolescents early on in this illness? This is just one measure we get out of it. This is called the POWERS. It was developed by Bob Post. We're looking here at child mood instability from the parents' point of view, from parents' weekly ratings. We send them a text messaged questionnaire where they're asked to rate the kid on these 0 to 3 scales of mania, depression, anxiety, ADHD, oppositionality, and overall illness. This is one particular kid followed over about 6 months. And what you'll see if you look at this carefully is first, when the kid is manic, so to speak, the parent also rates them high on anxiety and ADHD and oppositionality. So these fine-grained distinctions we make of mood states are not necessarily always apparent to parents. They may see them as manifestations of the same thing, even though we define what we mean by those terms. But you can see periods of stability versus fluctuation. Over the course of time, we want to match this up with what's at the top, which is the kid's medication regimen. You'll see here that the addition of methylphenidate seemed to help with depression, but there's still some fluctuations on the manic side when that drug was added, although Lamictal was increased as well. This will, I think, allow us to get a sense of what medications are helpful at what times and how do you map the trajectory of these illnesses. So here's Our website, if you want to get hold of any of our handouts or our treatment manuals, the FFT treatment manuals is downloadable from this site, Child and Adolescent Mood Disorders Program. So go and take whatever you want from that website. And also just want to let you know about this book coming out in fall. This is a piece of shameless self-advertising. This book is coming out in the fall from Guilford Press on living well on a day-to-day basis from what we've learned in our psychotherapy studies. So I thank you for your time, and to Ben for inviting me, and hope that information is useful. Thank you.
Thanks so much, David, and thank you both of you for leaving us time for a discussion. Maybe I'll take the first question and let folks think about what they want to ask. My question relates to the idea of moderators, or in terms of for DBT, looking at high emotional dysregulation, and for FFT, looking at high familial expressed emotion. It's clear that those interventions are engaging their targets. I'm wondering what you guys make of those people that are low on either one or both of those, and what we can do with them in terms of psychosocial treatments.
You want to go ahead, Tina?
Yeah, I think that these are all empirical questions. I think, my read of the literature is that these evidence-based approaches on average work well, regardless of where folks are starting, particularly if they're clearly diagnosed using semi-structured interviews with bipolar spectrum disorder. So, I think there's good reason to think that these evidence-based approaches work well for those folks. I do think there's this question about kind of individualized medicine and where do we start based on any particular patient's profile. And so I think there's plenty more to do in the field in terms of thinking about what is the appropriate dose and what is the appropriate approach based on any individual's profile. And I think, to be quite frank, I think we know less about that at this point in time, and particularly for folks who are presenting strictly with a bipolar diagnosis, aren't high on some of these other indicators. So then the question is, where do we start?
Thanks, Tina.
It's a good question, Ben, and it reminds me of something I heard from Alan Kasdan once, which is behind every moderator is a mediator. So whenever you find these moderators, there's something, a different causal pathway between that moderator and outcome. And I think expressed emotion is a good example. We got interested early on in what do high and low expressed emotion families do that's different. And we figured it was that they always criticize more. There are always these more electric interactions that get out of hand. That didn't always turn out to be true. There were people who had very negative attitudes towards the person, but their communication was fairly calm. And there were those who, really ripped into the patient. And when we interviewed them, they were fine in the way they talked about the patient. So you really have to conceptualize a treatment, I think, based on what the individual and family are going through. Even if statistically we find these moderated relationships, I don't know that they really are strong enough to say we should treat this person and we shouldn't treat that person. I don't think our science is that far along.
Thanks, David. So I'll turn to the audience. Feel free to unmute yourself and ask, or type a question in the chat. Okay, I'll ask another question. So this relates to parental psychopathology and the idea, maybe Tina, like for DBT, for example, we see a lot of parents who are highly dysregulated, and although the treatment outcome mainly focuses on the child, you can't underestimate the effect of that parent gaining control. And I think the same would likely be true for the expressed emotion. Wondering your thoughts on how that's been measured, or just the idea of parent as treatment target as well.
Yeah, I love that question. I think theoretically, I could not agree more that, and that's certainly clinically the feedback we get. So for so many of these families, we know bipolar disorder is a highly heritable illness. For so many of these parents and other family members, they experience their own emotion dysregulation, whether that's bipolar disorder, other presentations. And so the family members are really benefiting from the skills as well. And I think that's absolutely true in FFT too. I think we did not measure parental affective dysregulation or other symptoms, though I think that would be a wonderful addition to future studies to better understand, because oftentimes we think about within these family models, you know, the way that one individual in the family, their emotion dysregulation can then impact the emotion dysregulation of another family member. And, you know, frequently I, you know, talk about the way that these things can spiral over time. Not to mention the impact that things like sleep and circadian rhythms of a parent, a caregiver can impact those of the child, and David's beautiful example of the child impacting those of the parent as well. So I think there's, you know, so much potential to better understand these, you know, bi-directional relationships between, you know, members of a household and their impact on mood symptoms.
Yeah, just the only thing I'd add is, when we're working with kids who have bipolar parents, which we often do, we try to use the parents' experience in the therapy. So we try to say, look, you've gone through this. Are you willing to share with your kid what you went through when you had manic episodes and depressive episodes? How did you come to terms with having medications or the diagnostic stigma? Can you tell your kid about that? Now, if it's a younger kid who still respects their parents, then yes, they'll be open to this. Teenagers don't tend to like to think about themselves as being like their parents, so it's a little trickier. But I think you have to bring that in and encourage families to talk about it. I think we have one hand up, Bradley McIntosh. Bradley?
Yeah, maybe I was sort of typing my question there, but two lovely talks. Thank you so much. My question is actually for Tina, and I'm curious to know about whether there was consideration of pre-stratified subgroups based on suicidal ideation and attempts, like, because the 2x2 results that you showed there were quite striking.
Yeah, so we did stratify based on lifetime history of suicide attempt because, you know, we had reason to believe based on the literature that potentially that would impact risk of suicidal behavior over follow-up. And so that was evenly distributed between groups due to the stratification at baseline. Did that answer your question?
Yeah, it did. That's great. Thank you.
Okay, so we're thanks, Brad. We're very quickly up on time here. So I just wanted to thank both of our speakers, David and Tina, just fantastic, complimentary. I think that the overlap is interesting, as are the distinctive factors, and I'm hopeful in the next coming years we figure out, like we do for medications, how to allocate interventions to people based on their own experiences. So just an encouragement to please let folks know about these Toronto Bipolar Research Rounds. We have these amazing presenters next month. Thursday, May 16th, again, is Dr. Sophia Frangu and Steve Strakowski, who are going to be talking about their views on the evolution of imaging models of bipolar disorder. We're open to suggestions about luminary speakers and anybody else that you think might be interested who's conducting research or doing clinical care in this area. So thanks, everybody, and have a great rest of the week.
Thank you, Ben, for
Thank
inviting
you so
us.
much.
Thank you.